are going to discuss on respiratory symptoms. We have Dr. Sreedevi Warrier as our faculty here. I think all of you are familiar with her. We had a session with her on communicating bad news and pollution. Without further interruptions, I'm handing over to her. Sreedevi, Doctor, please. Up to you, ma'am.
Good afternoon, everyone. So today we'll be talking about respiratory symptoms. I'll be asking you questions and I'm expecting responses from all of you. So hope you all will be interactive throughout the session. So just for all of you to remember what we have learned in the undergraduate times, maybe first and second year of your education. Just to remember the parts of respiratory system. I'm not reading everything, but you have to focus on the trachea, bronchus, both lungs, right and left, all the lobes, and the alveoli, and the diaphragm. So you know that there is a parietal pleura which surrounds the lung on both sides. So whenever this is just for you to understand when there is a pathology, how it is going to cause breathlessness, because we'll be discussing the reasons for breathlessness in the coming slide. So I hope that is a quick revision for all of you. Nasal cavity, and we know that you have a lot of nasal sinuses around it, larynx, pharynx, and then trachea dividing into two bronchus to both sides. We know that the left bronchus is slightly longer than the right. Yeah. So we know that how important respiration is, right? Morning when you go to your patients and taking the vitals, the one vital sign that you take is respiratory rate, right? You check the pulse, BP, temperature, and you always check the respiratory rate. So as nurses, from morning routine with all the patients, you are related to something related to the respiratory symptoms, respiratory system. You all look for the respiration. I hope so. So we'll listen to two stories, two patient scenarios. One was a 50-year-old male. So she was referred to us by the pulmonologist. She was diagnosed, she suddenly started having cough. She was not asthmatic. Suddenly she started having cough and shortness of breath. So she went to local hospitals. They gave some medications like antibiotics and bronchodilators, but she didn't feel good. Then they referred her to medical college. There they saw a lot of radio opaque lesions. Almost all of the lung was occupied with lesions. And they took the biopsy and they understood that these are all lesions from a unknown primary. So she had a cancer somewhere which is spread to lungs, and the lungs were full with tumor, tumor mass. And she was having severe breathlessness. She was admitted in the ICU. She was on continuous oxygen. Then they got this diagnosis. They told, see, it's widespread secondaries. So they don't even know. As you all know, that if there is an unknown primary, the prognosis is very bad because we can't treat unless you know where the primary is coming from. So they told you can go home, but at home you have to maintain the oxygen because she cannot get rid of the oxygen, not even for a minute. So the husband was clueless. She had two daughters, both the daughters were married, and the husband did not know how to manage the oxygen at home. Then he checked with many people. It costs a lot of money for having an oxygen cylinder because then they need to change every now and then. Oxygen concentrator, they can rent it, which they charge 1,000 to 2,000 rupees per day. And this person was a daily wage worker. So he doesn't know, he did not know how to take his wife home because of the need for oxygen. This is another very another situation where we encountered a few years back. I still remember that patient's face. He was a very young male who was working in a Gulf country. Suddenly started having breathlessness, and he came back to Kerala for doing investigations, and they put him on continuous oxygen and was diagnosed with asbestosis. We have learned about this, right? But we don't see much of patients with asbestosis. So his whole lung matter was filled with asbestos particles. He was unable to breathe. He had a very small child. He was basically from Tamil Nadu. For the treatment needs, he came to Trivandrum. A wife, and they don't know the language. They can't understand Malayalam, whatever these doctors are talking. And a very small kid, and he could not live without oxygen. He was on continuous high flow oxygen, unable to talk, unable to eat, and he was in intensive care. And he was also referred to palliative. So now you see both these patients were seen by pulmonologists. They could not manage their breathlessness even with oxygen. Both these patients were very, very breathless. They couldn't even talk when I saw them. So now we see how we can manage these kind of patients. What will we do when we get such a reference? We think that the pulmonologist can manage all sorts of breathlessness, right? So these kind of patients are the patients who are getting referred to palliative. So we know that breath is not just a physiology. We know the physiology, how we breathe, how the diaphragm moves, how the muscles move, what are the primary and secondary muscles involved in respiration. But breath is something more than it. Many a times when we are sad, when we are happy, when we are anxious, we communicate through breath. When we are sad, the way we breathe, the way we sigh is different. So it is not just taking in air, exchange with the blood, and putting the carbon dioxide out. It is also a language that patients or the people speak to each other. It has its own psychological and spiritual hints. As I said, when we are sad, when we are angry, when we are happy, we communicate through breath many a times. If you notice from now on, you'll understand the breath changes when you are angry, happy, or sad. And according to the definition, I am just mentioning that part in the red. It is a very subjective experience. Something which you feel the patient is breathless, patients may not be breathless. So it is very, very subjective. We heard in pain that pain is very subjective, right? For me, my pain is big. For the patient, their pain is big. So same as that, the breath or the breathlessness is also a subjective experience of breathing discomfort. So how commonly we see breathlessness? Dyspnea can be perceived only by the person experiencing it. We can't say how breathless the person is looking at them. It is very commonly seen in lung cancers. As you see, almost 87% of patients with lung cancer will have breathlessness. And not just in lung cancer, many of other issues, like it can be related to lung, it can be related to some other system. For example, in AIDS, heart disease, renal disease, or even in any advanced cancer. It need not be lung cancer, it can be any advanced cancer. Patients experience breathlessness, especially towards the terminal stage. And when people are dying, the breathlessness increases towards the last 3 months. How many of you have seen patients dying? Or your loved ones at your home or in hospital? How many of you have seen someone dying in front of you? Can I see some hands or chat or something? I'm waiting for your response. Have you seen someone dying? No. I got one response. Yes. Someone has seen, someone has not seen. Rest others, are you not listening? Yeah. Sister Kanjan is also seen, I guess. Yeah, at least some of you have seen. I'm sure even if you have seen your grandparents or your loved ones at home, towards the end stage, they'll have more of breathlessness. Even if they don't have cancer, even if they are dying naturally, any natural death, towards the end stage will have a change in respiration. The respiratory pattern changes completely from normal. So it is very important to learn how to give comfort when someone is breathless. And I'm sure at least one or two among this group have bronchial asthma. It's very common, right? At least some of you might have experienced some kind of breathlessness in this group itself. At least during the COVID time, many of you might have gone through breathlessness. We know that how difficult it is to tackle that symptom. So people describe breathlessness by two patterns. There are two patterns, like we say in pain also, no, continuous pain and a breakthrough pain. Same way, there is a continuous breathlessness and a breakthrough breathlessness. In breakthrough breathlessness, you'll not have breathlessness all the time. You'll have acute exacerbation. Sometimes when you move to the toilet, or sometimes when changing clothes or doing some exercise, then you have more breathlessness. Most commonly seen type is the breakthrough breathlessness. And there is a study which says that in non-cancer, there will be breathlessness significantly all of this time, like continuous breathlessness. But in cancer, you see increase in breathlessness towards the end of life stage. And if you remember the pain assessment, we ask people what kind of pain you have. Is it pricking, piercing, burning, tingling, all these qualities of pain. Same way we can think about qualities of dyspnea. Okay, we have to assess dyspnea the same way that we assess pain. We have to ask out of 0 to 10, how intense is your breathlessness? You can tell them to score the breathlessness. You can ask about the quality. What are the quality? Sometimes these are the three most commonly seen type of breathlessness: air hunger, work, and tightness. And all these three qualities happens through different pathways. I'm not going into details about pathways, but you need to understand what they are experiencing, because a thorough history is the key for good management. So we talk about air hunger. They feel that they cannot get enough air, hungry for air. Usually patients say, I cannot get enough air. My breaths don't satisfy me, or I'm starving for air. This happens when you do some exercise. If you do some exercise in the morning, then you feel even if you breathe, you don't get enough air. That is called air hunger. I'm not reading the centers involved. If anyone is interested, how this is different from other types, you can go through the PPT. Second is work or effort. We see that I need a lot of effort to breathe. I need a lot of effort just to get my breath. It is an effort to breathe, or my breathing requires more work. This is how patients will tell you. I have to put in a lot of energy just to breathe. They feel, and the third is tightness. They feel there is chest tightness. Many of you might have experienced that when you have an infection, or a lower respiratory tract infection, or during COVID. There is a chest tightness because there is a bronchoconstriction happening. So these are the three types of quality of breathlessness. One is air hunger, that is, I can't get enough air to breathe. Second is a work, I need more energy to get a breath. And the third is chest tightness. So, what is the pathophysiology? I'm not going into the cerebral cortex or your breathing chemoreceptors and everything. This is the thing that we need to understand from now on. Any kind of breathlessness, people relate that to death, right? If any one of you have experienced breathlessness, when you become breathless, you feel that I'm going to die without getting proper oxygen. I'm going to die now. So when someone has an illness like a cancer or a COPD or an interstitial lung disease, they feel that they are going to die very soon. Many patients, I have asked them, like, what is that you feel when you are breathless? So they become so anxious, their facial expression changes. They think that death is right in front of me. So any anxiety can increase breathlessness. So imagine that you are going for an exam, your final year exam, and you're very anxious. When you're very anxious, have you noticed that you start panting because you're anxious? Your breathing pattern changes. The moment the breathing pattern changes, you become more anxious because it's a constant reminder of your anxiety. So even for an exam, we all go through that. So when someone has an illness which is incurable or progressed to an advanced stage, when they are breathless, they feel anxious. When they are anxious, they become more breathless. When they become more breathless, they think that they're going to die, which make them more anxious. So it is like a cycle. You understand? So it's very important to break the cycle, to reduce the fear of dying, to reduce the anxiety, and to reduce the feeling of breathlessness. So this is a very important model, which is called breathing, thinking, and functioning model. There are a lot of studies in recent days about this breathing, thinking, and functioning model. It is very similar to what I said. When you think, when you are anxious, when you think about dying, you think about misconceptions that people will tell that if you start becoming breathless, that means you are going to die soon. All these misconceptions, memories. I have seen someone dying of breathlessness. So those memories can cause more breathlessness. And when you are breathless, they don't want to move, right? If the patients start moving around, then they become more breathless. So they don't move. If they don't move, what happens? Muscles will become weaker. When the muscles are weaker, they can't breathe properly. Again, that is another cycle. Then they don't move, their muscles become weaker, and then they can't breathe properly. Or that effort is more needed is more to breathe. So it is breathing, thinking, and functioning as a cycle. Everything is interrelated. So we have to break this cycle at various places. It is not just about giving one drug and relieve the breathlessness, but it is about approaching all these cycles and break the cycle. So, what are the causes of breathlessness that we see in palliative care? In your routine hospital setting, you might be seeing some other causes, but in palliative care, it is usually either due to primary or metastatic lung cancer. Second thing, if there is a tumor, if there is a malignant tumor, there can be lymphatic infiltration by the tumor. So it may not be due to the tumor in the lung, but it can be due to the lymphatic infiltration by the tumor. I don't know how many of you have seen pleural effusion. So in the beginning, we have seen a picture. So you have a lung. Around that, there is a layer of pleura. So between the lung and the pleura, there is a space, right? Where you have your surfactant, which helps in increasing the lung capacity. When you breathe, surfactant helps you to have becoming a cushion between the pleura and the lung. So in that space, the fluid from the malignant cells get accumulated. So the lungs cannot expand when they breathe because it is filled with fluid, right? You might have seen pneumothorax or hemothorax if you're working in an ICU setting. But in malignancy, you can see malignant pleural effusion, where the pleural space will be filled with malignant fluid or infiltrate. Then, if there is a tumor in the trachea or near the bronchus, what happens? It will compress the trachea or bronchus from outside, which will cause again breathlessness. Some of the surgeries or some of the radiation therapy can cause constriction and can cause breathlessness. So these are the primary causes that we see in palliative care setting. Other causes for breathlessness, it can be due to heart failure. You might have seen patients with congestive cardiac failure. You might have seen patients with renal failure. All these patients will go through breathlessness. And other causes like COPD, infection, a pneumothorax or a hemothorax, or it can be due to a pulmonary embolism. Road traffic accident, it is very common. Many surgeries, you end up in having a pulmonary embolism where they will have severe breathlessness. So what are the other causes? Now we heard about this primary illnesses, secondary comorbid illnesses. What are the other causes leading to breathlessness? Pain. If they have severe pain, patients will experience breathlessness. It comes as a cluster. Pain and breathlessness and pain. Along with that, there is a third thing, which is anxiety. As I said, when there is pain and breathlessness, people will feel anxious, which will cause more breathlessness. And we know that many of the cancer patients will have bleeding tendencies or decreased hemoglobin. Most of them will be anemic. So anemia itself can be a reason for breathlessness along with other metabolic disturbances. So what we need to understand is that it is not just in lung cancer that you're going to see breathlessness. You see breathlessness in any advanced illness. especially when they are progressing towards end of life. So that is one thing that you need to understand. And for that, we need to take a thorough history and do a good physical examination. Examine the chest, examine whether the chest cavity is moving uniformly. Is there any decrease in movement on one side? Palpate, do the percussion just to see whether there is any change in sound when you percuss, whether there is resonance, whether there is dullness, and listen to the chest. Always auscultate. Even if you are nurses, doesn't matter. You have to do or learn all these things. These are very simple things. We all learned that during the undergraduate time, right? But we don't use it because doctors are doing it already. History, examination, and very importantly, their emotional needs. When someone is breathless, ask them what they are thinking, what they are going through, what makes them anxious. So you have to have a conversation. So, like I said, like pain assessment, where we ask about PQRST, right? You have learned how to assess pain. We ask palliating provoking factors, quantity, quality, whether it is a temporal, whether, when did it start, onset, everything we will ask. Same way, you have to ask all the questions in breathlessness. Quality of dyspnea, what do they feel? How do they explain their dyspnea? Is it constant or is it like intermittent? What is the intensity out of 0 to 10? How intense is your breathlessness? How does it affect your life? Many people, like we heard two stories in the beginning. Both of them could not talk to their loved ones. They know that they're going to die, but they could not talk because they were on oxygen all the time, 24 hours. So they couldn't sleep. They couldn't go to the toilet. They couldn't brush their teeth. They couldn't eat. They couldn't smile. So we have to ask how the breathlessness is impacting someone's life. And very importantly, imagine that you are seeing your loved one in front of you, very, very breathless. They can't breathe. Now you are breathing normally, but they can't breathe. So it is very important to ask or talk to the patient's caregivers about their concerns. So I still remember we had a very young boy in his 20s with an end stage cancer with a lot of lung infiltrates. So when he became breathless, he started running around in the room and scratching the walls. So I just asked, like, why did you do that? Once he was admitted and his breathlessness was treated. Then he told that time I wanted to dig a hole in the wall so that I can get some air to breathe in. So he was so desperate to get some kind of air from somewhere. And he felt that he's a fish under the water where he could not get anything to breathe. So we have to ask them, what do they go through? And there are certain scales that you can use in breathlessness to assess breathlessness. This is the most widely used scale. This is very important one. You need to know this name. That is Modified Medical Research Council, MMRC scale. Many of you might be seeing or using that in your hospital setting. I'm not sure if you are in a teaching institute, you would have definitely seen this scale. It is MMRC scale. It is very simple. 0 means there is no breathlessness, and 1 means when you are climbing up or when you are rushing, you have breathlessness. And the second means even if you walk on a plane level, normal pace, you are breathless. And 3 is you walk for 100 meters and then you really have to stop for breath. And 4 is even for dressing or undressing or to leave the house, you can't do that because you're very breathless. It's very, very easy to ask. Or even when they tell you the story, it's very easy to understand and put a score for that. So this is very important. This is for your understanding. There is another scale called Modified Borg Dyspnea scale. This is another scale that you can use in your setting, which is kind of mild, moderate, severe. But I think MMRC makes more sense for patients many times. So what are the physical signs? When you examine with your eyes, you have to position the patient and see how the chest is moving, see whether the trachea is the normal, is it deviated to one side. So these are all very important. Check whether their accessory muscles are moving, they're struggling for breath. Check whether there is a nasal flaring. Check for respiratory rate and gentle percussion and auscultation. And if you think there is an investigation is needed, which is going to change your treatment plan, then you can think about it. So, how do patient or what are the reasons for breathlessness? Severity of dyspnea, you have to ask. Either you can use a MMRC scale or you can use simple 0 to 10 scale. Check what are the precipitating factors. What is the aggravating factor? Is it a physical activity? Is it a mechanical factor like crying, laughing? Or is it emotional? And then ask whether it is continuous or episodic. Ask for past medical history, whether they have COPD, interstitial lung disease, tuberculosis, motor neuron disease. So everything you have to check. Whether there is any occupational exposure. I never thought I would see a patient with asbestosis in my life. And I see at least 3 in last 10 years. So these are things which we may not expect to see, but it's good to ask those questions. Check whether they are taking beta blockers. We know that many of the anti-hypertensive hypertensive drugs like the metoprolol kind of group of drugs, many of them are beta blockers. Many of them can cause breathlessness. And ask whether there is cough, blood in sputum, wheeze, stridor, pain, everything you have to ask. So what are the management? First thing is to ask the wishes of the patient and check whether we can send them for investigation. So see, suppose someone is coming to me, I examine and I think there is a pleural effusion. In a hospital setting, you have to take an X-ray or any other investigation to see whether there is pleural effusion. In a palliative care setting, the patient cannot go to a center to get a chest X-ray done. So it is okay. You have to rely on your assessment findings and to think whether how my treatment is going to benefit this patient. Think whether the patient is going to die or it's something that very early stages of illness. Then only we can plan accordingly. We have to include the patient and family in the decision making. So these are some of the pictures. This is a part of a research project done in another university in UK. If you can Google it and see their website, they asked people, what do they feel when they are breathless? So they say, I feel so good. My life is good, but then I can't breathe. You can see the picture on the right where the head is completely inside a cloud. You all love cloud. We want to be in the sky, but suddenly you are in a good space, but you are covered with cloud. You can't breathe. And then you are all alone in one road. So there are several strategies that they have studied, that you have to ask for help. You have to respond to the needs of the body. And they have to cope by disengaging yourself from the symptoms. So it's very interesting study. They have come up with a lot of pictures where, then there are many other interesting pictures where someone is sitting inside a rose garden with a lot of thorns. So roses are beautiful, but the thorns are paining, right? So they have explained what they go through through various pictures. They have done a photo exhibition based on this. So another thing, there is a disparity between what we perceive and what they go through. Suppose a patient is coming in front of me, panting, I'll think that, oh my God, this patient is having severe breathlessness. But the patient may not feel the same thing. They say, no, I'm okay. I'm like this from many years and this feels normal. They're okay, then that's fine. Sometimes they sit comfortably, but they tell you that I have 8 out of 10 breathlessness. You are not seeing it. You think, okay, this patient looks okay. But the patient is telling you there is 8 out of 10 breathlessness. So there is a study done where they understood that many a times doctors or nurses misinterpret the breathlessness. And they treat, thinking that they have breathlessness. So it is very important to ask exactly what they are going through. Think about the correctable factors. If there is a pleural effusion, you should drain the pleural fluid. You don't need to give any medication, just drain the pleural fluid, then they are completely symptom free. If there is any pneumothorax, definitely you have to treat that. If there is a congestive cardiac failure, you have to treat the fluid overload. So understand whether there is something correctable. Sometimes they can go through a radiation therapy, they can go through a surgery by removing the tumor mass. Sometimes a chemotherapy can reduce the breathlessness. So understand whether there is any correctable. Should I refer this somewhere so that they get some relief? There is any corrective measures to be done. Very, very important. So I've not talked about any medication so far. I don't know whether how many of you have noticed. For the treatment of breathlessness, the most important part is non-pharmacological management. You don't need drugs all the time to manage breathlessness. The non-pharmacological management should come first. And there are a lot of studies. I found it very silly when I heard it for the first time. I was taught by another faculty told that handheld fan has a lot of importance in treating breathlessness. So I was thinking how a fan can treat breathlessness. So they say battery operated small handheld fan, you get it in Amazon. Sometimes we can connect it to your laptop or you can keep it in your hand. So they say the handheld fan is very, very useful in breathlessness. So you have to keep the fan on the side of your face. They say some of the nerve stimulation happens and they feel subjective relief in breathlessness. Plenty of studies based on fan, how to use fan for reducing breathlessness. It is very different from what we practice, right? In your home, when you have breathlessness or cough, people switch off the fan first. Oh, fan, you can't have a high speed fan because you are coughing or you are having breathlessness. Or you close all the windows thinking that the air from out can cause you more breathlessness. So ventilation, proper ventilation and handheld fan and passive exercises. You don't need to do exercises. At least you move your limbs, maybe legs, any muscle movement, any small movement is very, very important. Positioning, proper positioning. So this is very important for you as nurses. How can you relieve breathlessness without using any of these medications? How will you position the patient when they are breathless? Can you type it in the chat? In your hospital or at your home, if you see someone very breathless, how will you position them? Will you tell them to lie down supine or prone? Of course, in COVID, we all saw about the prone ventilation, but apart from that, Fowlers, yes. Any other position you have seen where patients find Fowlers propped up? Propped up, yes. Yes. So they can't lie down supine, right? They need to have a prone position. Sometimes we recommend tripod position. Have you heard about it? Just keep your hand like this on a cardiac table or the table on your in your home. We tell the patient to, or you can keep a stack of pillows and lie down like this. Many patients find it very, very useful to breathe. It's not prone per se, but it is called tripod. You are using your hand as a tripod and lean forward. If you have seen patients with severe breathlessness with COPD, generally they lean down like this to get more breath. So this is one position people prefer. Or if you have a pleural effusion on one side, they prefer to lie down on to one side. Or if they have a tumor on one side of the lung, they prefer to lie down on the other side. So positioning is very, very important. Give a walking aid. Suppose a patient is having severe breathlessness. Okay, they have to go to the toilet. So they are using all their energy to walk. We need energy conservation. We need to conserve energy. We need energy for breathing. That's the priority here. So how can we utilize energy from other muscles? You give them a walking aid. You give them a walker. So their support is mostly going to the walker and they don't have to use a lot of energy for walking. So they feel a little bit comfortable in breathing. So you have to conserve your energy. If they don't need to go to the toilet, if you can manage bedside, well and good. But if they need to walk, and pacing the activity. Morning itself, changing clothes, taking bath, feeding, everything cannot be done together. One time you change the clothes, let them settle down. Give a shower, let them settle down, then feed, let them settle down. So you have to pace their activities, encourage them to use walking aids. Explain to them. If you tell them, can you please use walking aid when you go to toilet? They feel I don't have any problem in my legs. I can walk. Why should I use a walker? So you have to tell them that you need energy to breathe. So don't waste your energy by walking. Use a walker. When they are sitting, simple thing, when they are sitting on the bed without support, they need more energy to sit like that. Give up back support. So they need less energy to sit up. They can breathe properly. So these are simple things that you should tell your patients. So, and we look into pharmacological management. So when I say oxygen, we think that how can it be pharmacological management? Oxygen is there everywhere in the atmosphere, right? No, but when you give oxygen, artificial oxygen, it is a therapy. It is an intervention. It is not something which is natural that you are giving. So what happens? They say that there is a big study conducted and they say that there is not much difference between the room air and the oxygen. They feel the same. Symptom is the same. So there is no correlation with dyspnea and hypoxia. So I'm not talking about the COVID. If you see someone very breathless, dying, some patients, the saturation will be normal. They'll be absolutely fine, but they'll be very breathless. So you can't relate the dyspnea and hypoxia. Sometimes it is completely not at all related. So oxygen plays very less role. So imagine there is that lady story which I told. The lung was completely filled with tumor mass. You give oxygen to that lady. Where is it going to get absorbed? You need to reach oxygen to be reached to the lungs through the bronchus. It has to reach the alveoli and it has to reach the blood. The alveoli is completely filled with the tumor mass and you give oxygen. Is there any point rather than making the throat dry? Because the patient's lungs cannot absorb or utilize the oxygen that we are giving. But I know that whoever has seen people dying, they die with oxygen. The moment the patient is breathless, then we put on oxygen, right? So the duty is done. We never ask whether they are comfortable or not. Is it giving relief? Have you asked after putting oxygen? Is it giving some relief? Generally, it is a relief for the caregivers and the nurses and the doctors because we have done something. But generally, the patients say, no, please remove it. I'm sure you might have seen patients keeping on removing the oxygen mask. You put on the mask, they keep removing. Then you tie their hands so that they don't remove the mask anymore. Is it a very common finding in your hospital? People keep removing the mask. I myself went for a simple procedure. I was not breathless. Someone put me an oxygen mask and I still don't know why. I kept removing it for talking. It's so uncomfortable. You sweat. It is very tight. It can cause rashes and you can't talk. So it's very important to understand the illness. You need to give oxygen when someone is desaturating due to COVID or someone is desaturating due to pneumonia, but not when there is an advanced illness where the lung is completely filled, fibrosed, cannot utilize the oxygen. So it is very important to understand whom you are treating. The very important point, the one medication that I will be talking about today is opioids. So we learned about morphine in pain, step 3, opioid. Opioids are very, very useful drug in controlling refractory breathlessness. When I say refractory, not responding to normal treatment. We have to titrate it carefully. It is not like usual pain management dose. We have to give low dose, go slow. We may start with lower dose and go slow, very slow. It has a huge impact in treating breathlessness. It is a mainstay of treatment for breathlessness in our setting, in palliative care setting. You give morphine, you can see the patients improving, but the saturation may not change. If you are giving morphine and checking saturation, there is no relation. But the patients will feel subjective improvement in breathlessness. They say that it reduces the perception of breathlessness centrally. So there are so many theories related to opioids, how it reduces the breathlessness, but I'm not going into detail because you don't need to know that many details. It's very important to start with the smaller dose of opioid. Oxygen is always another drug or intervention. Not all patients will benefit from oxygen. And if you're planning to give oxygen, give it through nasal prongs, not the mask. With prongs, people can talk. It's not scary. The mask is very scary and people cannot talk. Suppose when they are dying, they must be in their last few hours or weeks and they can't talk anything to their loved ones. They can't smile. They can't do anything because there is a mask here. So if possible, give a nasal cannula. So this is the mechanism of action of opioids. You can just read it. It reduces the perception of dyspnea in the brain. It reduces the perception of dyspnea and it will not respond much to hypercapnia. So when there is hypercapnia, that is increased carbon dioxide in your body starts reacting. It will keep getting in air so that the carbon dioxide is getting out in an effective way. But when you give morphine, that response is lost. Even if there is hypercapnia, you don't have a breathlessness, increased respiratory rate, and it reduces the anxiety also. So this is what we use. Usually, it is recommended to use sustained release morphine 10 milligram, but you can always use small doses, the immediate release morphine, either 2.5 or 5 milligram 6th hourly. So that is the only time, not only time, maybe in renal failure also. Apart from pain, when you give for breathlessness and in renal failure, it will not be 4th hourly. For pain, you have to give 4th hourly dose of morphine, but when it comes to breathlessness, you can give either 8th hourly or 6th hourly and a smaller dose. And sometimes we use the immediate release morphine. Another drug which we can use is dexamethasone. When you have a huge tumor mass obstructing your trachea or any other areas in the respiratory system, you can use dexamethasone, which will reduce the tumor edema and shrink a little bit so that they get some space to breathe in. Found very, very effective in many terminally ill patients. So that is one drug that you can use neosetine. Benzodiazepine. So we are talking about 3 drugs: opioids, steroids, and benzodiazepines. Very, very important to remember. Benzodiazepines will reduce the anxiety. We heard that anxiety can cause breathlessness. Breathlessness can cause anxiety again. So we need to reduce the anxiety. You can give drugs like lorazepam or subcutaneous midazolam to reduce the anxiety so that patient can be at ease when they have problems with breathing. So this is one flow chart. And you can see the first thing is non-pharmacological, right? I'm not jumping into morphine there, right? You use fan, you use the relaxation techniques, walking aids, rehab, maybe small exercises. Wherever this patient is, continue the non-pharmacological management as much as they tolerate. You can't say a dying person, give a fan and relieve the breathlessness, no. But as much as they tolerate, continue the non-pharmacological management. Simple things: open the window, move the cot towards the window, have some fresh air, loosen the clothes, give a proper positioning at home. So all this is very important. Plus the 3 medications that we taught: opioids, steroids, and benzodiazepines. So breathlessness is very common in cancer as well as in non-cancer. It is not just lung cancer that we are talking about any advanced illness. Very important is to ask a proper history, a proper assessment and examination. And we have to focus on correcting the correctable. Is there anything that you can correct there? If it is low HB, if it is due to anemia, can we correct it? Or if the patient is dying, then there is no point in correcting the anemia. So it's very important to understand where exactly the patient is and to give appropriate drug. And the most important part is non-pharmacological management is very, very important from the beginning till they tolerate the non-pharmacological approach. Other important point is the third point mentioned in the slide, that is respiratory secretion. When someone is dying, there is a lot of noise. If the people who have seen people dying, there is a lot of noise and change in breathing, which can be managed. This we will talk in end of life care session. I'll quickly go through another 1 or 2 symptoms, that is cough. Initially, we have heard about respiratory issues, and cough is very, very common. Sometimes it puts the patient that they can't sleep because of severe cough. And because of continuous cough, they will have pain because they're coughing all the time. Sometimes there is urinary incontinence because they are continuously coughing. So that is another symptom that is very difficult to manage and we often seen in palliative care setting. What are the complications? It can cause pain, ribs fracture, which I have not seen. Urinary incontinence, yes, very commonly seen. A lot of coughing. They have leakage of urine, sweating, exhaustion, and disturbance of sleep. And they feel social. We know that in COVID time, you can't even cough, even if it is an allergic cough, you can't get out in the public and cough. It is so embarrassing for many of us to cough. So it is same as for the patient. They can't talk because every time they talk, they cough. So they go inside one room so that they don't have to face anyone. That can cause isolation and psychological issues. I'm not going into the phases of cough, but what are the causes? Sometimes the tumor mass, as we said in breathlessness, involvement of pleura or aspiration. As nurses, you might be seeing this a lot. Patients with stroke or paraplegia or bedridden, elderly, neurological issues, they aspirate while feeding. So that is another reason, most common reason for cough. And there are some conditions where there is hypersecretion of mucus. For example, someone having head and neck cancer. There is a wound on the cheek. There is hypersecretion of mucus. So they will have cough all the time. Assessment is the same. Take a thorough history. Ask for underlying issues. Ask for the impact. Can they sleep? Is there any pain? Everything has to be documented. What are the treatment involved? Sometimes radiotherapy helps because it reduces the tumor mass and can relieve the cough. Again, very important medication is opioid and steroids. Both these drugs can reduce the perception of cough. Sometimes we may need to give antibiotics also if there is a chest infection. And we know that lot of cough syrup, when we have cough, we'll go to a medical shop and ask for a cough syrup and get it and drink it, right? There are several types of cough suppressants. There is a centrally acting cough suppressant, which is, you might have heard about dextromethorphan, which is named, I think, you get the lozenges, Alex lozenges and Alex cough syrup. It has dextromethorphan, it acts centrally. Some of the cough syrup like glycerol is more like a soothing agent. It will have menthol and you feel little good when it goes down. There are some class called protussives, which is mainly thin, make the mucosa, the mucus very thin. It is called mucolytic. It causes the secretion to be more thinner than the previous. So you might have heard about many cough syrup where they have this ambroxol and bromhexine combination. So there are different types of cough syrup. You have to understand the cause of cough and then give a cough syrup, not just any cough syrup for everyone. So, and again, benzodiazepines is another medicine that you can use, and gabapentin is one thing that you can use. Noisy secretions, I'll quickly go through it because we will be seeing that in end of life care also. So if you have seen someone dying at home, I'm not sure whether in hospital you actually see this, but if you have seen a natural death, there will be a lot of noise they produce while they are dying. Have you seen it? People making lot of noise when they die. Even at home, if you have seen someone dying. Any of you have seen noisy breathing? That is not a normal noisy breathing. It is slightly different. It is high pitched. You may be hearing it from the next room. Probably it's very loud and it is very distressing for the family. So what happens then? Why there is a noise? Because the person is dying. Their muscles may not work. So whatever secretions are coming in the pharyngeal and the oral and the pulmonary secretions, they get pooled in the back of the throat. They are lying supine, right? So all the secretions get pooled in the back of the throat. So when they breathe, the air is passing through the pooled secretion. So it's like when you have a glass of water, you blow it with a straw. You can hear the sound, right? Bubbling. The same thing happens because there is a pooling of secretions in the back of the throat, and when the air goes in and out, it makes a typical noise. It is not infection or it is not something distressing. It is just because of inability to swallow effectively because the person is crying and he cannot cough it out. So it gets just get accumulated in the back of. It is very commonly seen in patients who are dying, and usually they will die within 1 or 2 days when you start hearing this death rat. What can be done? The important thing as nurses, positioning. When they are lying down in the supine position, more and more secretions will get pulled in the back of the throat. You have to place them on one side. So it just comes out. It suddenly stops. So positioning is very, very important. Death rattle will not be a cause of distress for the patient. The patients will not go through any distress. It's just a normal dying process. But as a caregiver, the caregivers find it very difficult to listen to these noises all the time. They feel that, oh my God, my loved one is they are going through a lot of suffering, or they are breathless, they have infection, or it is a greater impact, negative impact on the staff also. We feel that, oh, there is something big happening. So understand that it is natural. A simple position change can relieve the symptom. Sometimes we do give drying agents, some medications which can dry the secretions like glycopyrrolate. Glycopyrrolate is an anticholinergic which can be given subcutaneous or sublingual. So it will reduce the secretion and reduce the noise. Hemoptysis, that is coughing the blood through sputum. Unless it is like massive hemoptysis, like 300 ml in a single episode of cough, it is not life-threatening. And it can be due to the tuberculosis, it can be due to the tumor mass or any infection. Usually, we give medications to stop the bleeding, like intravenous or oral, intravenous tranexamic acid or oral etamsulate. If it is a massive hemoptysis, then probably the patient might be dying very, very soon. So I'm just stopping my presentation there. I'll stop sharing the screen. If you have any questions, I'm happy to answer those questions.
If you have any questions, you can unmute yourself or put it in the chat box.
How many of you encounter or see patients with breathlessness in your setting? Is it very common, or you don't see patients at all with breathlessness? Do you see that in your setting? Yeah, so some, yeah, many times you see. So at least I'm sure that in our setting, we can't, nurses can't prescribe medications. That's a limitation. But you can always rely on non-pharmacological measures. That's very, very important. Just loosen the clothes, position them, put them towards the window, ask them, just talk to them. That's very important. And as nurses, maybe you can tell your doctor to remove the mask when you give oxygen and give the prongs. Simple thing, no, but they can eat. They can talk to their loved ones. They can smile. They can express themselves when it is not a mask. Mask is very scary. The moment you put on mask, it's very scary for many patients. They feel that they are going to die right there, right now. So these are the things that you can do in your capacity as nurses. Thank you for all those who have responded in the chat, because that's also very important, because I need to know where you come from, right? What all you have seen, Are you actually seeing all these kind of patients? These are very, very important. Thank you so much for the interaction. So if there are no questions, maybe we can start the case presentation.
We do have a case presentation by Sister Rafina today. Sister Rafina,
Yes, ma'am.
you can go on, please, ma'am.
Good evening, ma'am. Good evening to all. I am Rafina, staff nurse in MES Medical College, Perinalmanna. My presentation topic is CLN. Patient detail, age 58, gender male, diagnosis CLN. Presenting complaint, date of admission 13th August 2022, came with complaint of shortness of breath, persisting cough, weight loss, and weakness since 6 months, hoarseness 5 weeks, chest pain 3 weeks, hemoptysis 2 weeks, and loss of appetite 2 weeks. History of illness, 58 years old man, onset of disease 6 months, started with cough and shortness of breath followed by hemoptysis. Personal history, no history of comorbidities, chronic infection, no any medical and surgical history. He has history of smoking and alcoholism since 29 years. Family history, no history of malignancy in his family. Examination, physical examination, weight 55 kg, height 162 centimeter, vitals, febrile, heart rate 112 beat per minute, respiratory rate 44 breath per minute, BP 170 mm of Hg, and SpO2 97% with low flow O2. General examination, consciousness unoriented, cooperative, dried and wrinkled skin, thin built. Treatment and significant investigation, X-ray, bronchoscopy, CT scan, guided needle biopsy, sputum cytology, bronchoscopy, acute airway obstruction from mesoesophagus secondary to achalasia evaluated with flexible bronchoscopy. PET scan, not to medley hypermetabolic multiple bilateral lung nodules and right pleural deposit with moderate to gross right pleural effusion as described metastasis. Treatment, chemotherapy, carboplatin and paclitaxel, radiation therapy, immunotherapy, and palliative care. Psychosocial aspect, he has 4 children, 1 male and 3 female. All are married and his son is a painter and he is the breadwinner of his family. He is unable to follow proper treatment due to financial crisis. Patient is a widower since 3 years, so no one is taking care of him. Not able to have proper diet due to illness. He has lack of support for long-term treatment. Medication, injection Sonomax 1.5 gram IVBD, tab Sobras 40 mg BD, injection Dexona 4 mg IVBD, tab Pulmoclear BD, tab Ultracet BD, nebulization with Diolin 8 hourly, nebulization with Budamate BD, syrup rapid test 2 teaspoon TID, and low flow O2. Main concern, prevent the progression of disease, pain management, management of side effect of chemotherapy, prevent further metastasis, improve lifestyle, and advised to avoid smoking and alcoholism. Summary, 58-year-old man, old male, non-case of CLN was admitted with complaint of shortness of breath, cough and weakness, supportive treatment provided with antibiotic, bronchodilator and analgesic. Now his condition is better and discharged on 22 August 2022. Discussion point, pain management, prevent further infection, nutritional management, oxygen therapy, counseling and psychological support due to support to patient and family. Thank you.
Thank you, Rafina, for the detailed presentation. So based on the discussion that we had, now we heard how to manage this. This is a very good example of an end-stage respiratory issue, right? End-stage cancer, where she has mentioned that there is a moderate to gross pleural effusion from the metastasis, and the patient is breathless. And we have seen the medications also, right? So how anything that you want to add to this, whatever is being done? So I'll ask one by one. Do you think stopping the smoking and alcohol, if he is smoking, still smoking, is it important at this point? You can type it in the chat. So the patient is having massive pleural effusion. Is it and metastasis, progression of illness, very breathless, but he still wants to smoke. He knows that he is dying. The disease is progressing. You want to counsel him for smoking cessation. I'm just asking, like people will have different thoughts. Yes. So Shiny feels that it is important to talk about stopping the smoking. Anyone else? Yes. Nancy Joseph. Yeah. Anyone with any difference of opinion other than counseling the patient for smoking, stopping the smoking? Or am I the only one who feels that the patient is dying and it is one pleasure that he may have by smoking one cigarette a day? I would probably tell him it is okay. There is no time to stop slowly, Sister Evangeline. He might be dying. There is a big effusion, lot of metastasis inside the lung. Probably he might be dying. It's an advanced illness. So I still remember we had a patient with very advanced cancer, with a lot of metastasis to the lungs, and he was breathless. He knew that he was dying, very young patient, but he was very adamant that he wants a cigarette. He knew that he was dying. So why should I tell no to him? He knows that he is dying. We know that he is dying in another few days to weeks. Is it the time to tell him to smoke? Like that is one thing that he feels, okay, I have the power. Everything else, I'm admitted in the hospital. My wife decides when to feed. The doctors decide something. I'm losing my control over my own life. So he wanted to feel alive. He used exactly the same word. I asked, like, why do you want to smoke now? He told, I want to feel alive, that I'm still not dead. Just one cigarette. So every day he used to go out. We used to take him on the wheelchair and take him out in the garden so that he can go and smoke whatever he wants. He died within a few days. So we felt if I have told, no, you can't smoke, we are taking away the last, some happiness that he got from the smoking, right? I'm not telling to encourage smoking, but there are certain situations that we need to think whether there is time for all this, whether it is going to give some benefit to the patient. Is it going to help the patient? I'm not sure. So what are the other correcting the correctable that you want to do in this patient? One major thing can be corrected. There is questions like preventing the progression, preventing the further metastasis may not be possible. You can give all this immunotherapy, chemotherapy, but we can't be sure that it is going to prevent the progression. Yes, Evangeline, I will not tell the patient to, okay, you continue smoking. I'll still tell that it is better that you stop smoking. But if it is really important, giving him meaning, then probably I will just ignore that part. So is there anything that you want to correct here? Anyone? There is a massive pleural effusion. So the lung pleural cavity is completely filled with malignant fluid. The moment you take out that fluid, see the PET scan, there is moderate to gross right pleural effusion. Bilateral lung nodules and pleural deposits with pleural effusion. So if there is a pleural effusion, if you drain the pleural fluid, patients will usually get good benefit. They just completely get relieved for that night. That's very, very effective. Anything else? Any non-pharmacological management that you want to suggest? Any non-pharmacological management? Now we spoke a lot about non-pharmacological management. I'll wait for your chat or your response. Yes, chest physio we can give. Very, very good. Physiotherapy, yes. It's very important to make them do some passive exercises. The caregiver can just move his limbs. Breathing exercise is very good. Pursed lip breathing, we have to tell them when they are breathless how to do pursed lip breathing. Exercises. Anything else? I have talked a lot of non-pharmacological management in this session. Yes, spirometer can be used. It has to be taught first and then tell. Positioning, yes, very important. Walking aid. Some of you were actually listening and I'm glad to know that. Positioning, walking aid, opening the windows, proper ventilation, pacing their activities. All these are very, very important because anyway, this patient is now symptom free, but he may progress. He will come back again in another week telling that there is severe breathlessness. So I think Rafina, you can suggest your doctor if you have a palliative care unit. You can just ask, I heard that morphine can be useful in these patients with breathlessness because he has pain also, right? So you can gently ask your doctor, do you think morphine is going to be beneficial, doctor? He's on Ultracet. So he's having pain, he's having breathlessness. So instead of giving Ultracet, if you give low dose morphine, the patient will have good pain relief with good relief from breathlessness. So next time when the patient come with breathlessness, now you have learned, you have heard that morphine is beneficial, you can gently ask your doctor, do you think we can use morphine? I've heard that morphine can be beneficial. Can we use it? If you have a palliative care department, definitely you should be able to use it.
Okay, ma'am.
Do you have a palliative care department there in your institution, Rafina? You have a doctor and a team there?
Yeah, ma'am.
Okay. Then it is easy. You can just suggest.
Okay, ma'am.
Can we go back to the last? So again, what about oxygen therapy? So it's very important. We know that this patient's disease is progressing, right? So he will come back again with breathlessness in the coming days. Multiple times he can come back. So it's very important to have a conversation with the patient and the family. Like they will feel now he is relieved. He has gone back home. They will think that everything is all right now. So it is very important when they come back, you should talk to them regarding the prognosis. It can come back again. It can be breathless in another few days. If so, we think that these are the things you should do, or these are the medications. This is the plan that we have in place. So all these things have to be communicated very early because when they are breathless, no, they just lose their everything. They can't think, they can't take a decision. You can't have a conversation then when they are in severe breathlessness. So it is very important to have the conversation. Now he has some relief. It is better to have the conversation now, plan ahead. What happens if the disease progresses? What is that you want to give? You want to be at home or you want to come to hospital and get admitted here? You want to have injections. So all these small things have to be discussed with the patient. And ask them, what do they feel when they are breathless? They will be definitely scared about death. If you just ask that question, you will understand. Everyone invariably tell you that when I'm breathless, I think I'm going to die. It is very scary. So it is very important, as someone mentioned, teach them exercises. Along with that, teach them how to relax. All these relaxation techniques also you should tell them so that the anxiety is reduced. When the anxiety is reduced, the breathlessness is also reduced. So it is not just giving morphine. It is about all the non-pharmacological things and having a proper communication about them. Prepare them. Because if something happens in future, no, if you're breathless, you can't have a conversation. It's very important to prepare the patient and the family for the coming days and ask them what do they want to have when there is a crisis. Is there any other question, either from Rafina or from others? It is okay not to have questions, but we send out the assignments. We expect all these things to be on paper. That's the only thing I wanted to tell you. It's okay not to have questions. Maybe you understood or you did not understand, but all this will be asked for your assessment. We need to see everything on the answer sheets because whatever is being asked is being conveyed through all the sessions. So just make sure that you clear your doubts during the session. I'll wait for one more minute to check whether there is anyone having any questions before we end today's session. So if there are no other questions, maybe we can wind up today's session and we'll see next day with another interesting topic.
Thank you all for joining us today. Thank you, Sreedevi ma'am. It was in a sudden moment you agreed to take the session when our faculty got into some emergency situations. Thank you so much for that. Bye. I will see you on the next session. I have shared the feedback link in your WhatsApp group.